Yeah.
It's 88 right now.
I wish I was in 88-degree weather right now. Wow. Kadishia, stay on after and we'll schedule something. Okay. I don't know who student is. Is that
Celine.
who? There's somebody on here that says student.
No, I don't know.
Celine, that's you.
It's me.
Yeah.
Well, it's me.
You're on mute.
Celine Broussard.
Celine. Can you put your name on your let's see, do we have everybody? We do, great. Awesome, awesome. How's everybody doing? I need everybody's cameras on. And I need to see your faces, please. I can't believe it's week 5. I don't know where the time has gone. How's everybody doing for a Monday?
Good.
Good, good. Okay. Anybody have any questions or bring up anything before I get started? So today we're going to take our quiz 3 at the beginning here, and then we'll review. It covers a lot of information. The last 2 weeks, we've covered a lot of content, or where a lot of concepts were covered in your readings. So this quiz was kind of all over the place with different topics. We'll review it after you're finished. And then we'll go through content from weeks 4 and 5. And we'll take our time with the quiz, because going through all the questions in the quiz, we can do a lot of our content there as well. Okay. Does anybody have any questions? Well, with regards to the exam, kind of mixed for this class. A lot of people over 78, quite a bit more than I would like to be under 78. So I've had a lot of students reach out to me already to schedule a time to review the exam, review the concepts missed in the exam. But I'm also waiting to hear from several students who scored below a 78. So I really would like to review the concepts missed. I truly believe it's very beneficial to go through the concepts missed and identify what kind of questions you missed. I've already had several tutoring sessions today, and they've been very successful. I mean, students appreciate going through the concepts missed, and we discuss maybe test taking strategies for the next exams. So if you haven't reached out to me yet and you got score below a 78, I would highly encourage you to do that. Okay. If you got above 78, congratulations. And if you would still like to review what you missed, I'm happy to do that. I met with a student earlier that actually scored, I believe, a 94, and that student wanted to know the few questions that she missed. So I appreciate that. So it's up to you, but I really would like to review with you guys. Okay? Anybody have any questions before we get started with the quiz?
Miss Martin.
Yes.
Hey.
Hi, Vanessa.
Hi, how are you?
Good, good. How are you?
Good. I've been having some Wi-Fi connection problems. Like when my first class this morning, it kept logging me out.
Okay.
So I'm just letting you know if it logs me
Okay.
out, I'll just hop back in.
Just pop back in. Okay. Thanks for letting me know, Vanessa. I appreciate that.
Mhm.
Okay, so it is 3:04. So let's take 15 minutes to do the quiz. So that will take us to 20 after 3:20. So quiz 3 is open for everybody. Take your time doing it. It's 10 questions. We'll do 15 minutes. I don't need to know when you're done. You can just keep your cameras on, okay? Got to keep your cameras on for the quiz. But if you finish early, just keep your cameras on. If you need to go take a quick break until 3:20, that's perfectly fine. Okay? And then make sure you hit submit after you take it, so that we can review it together. Okie dokie? So go ahead and take the quiz. Take your time. You got a full 15 minutes. Okay, how we all doing? Everybody done? DeChantel, you done? Yes? Okay, great. Okay, how do we do? Let's go ahead and review. There's a lot to cover on this quiz, lots of different concepts. I sent a couple of messages to students in the chat. I think I sent 4 messages. So if I sent you a message, if you could respond at some point, no big deal. Okay, let's take a look at the quiz. Can everybody see my screen? Okay. As you can
Yes.
see, the quiz covered a variety of topics from last week and this week. Okay. So first one, and we've talked about this, you've got to have an understanding of primary, secondary, and tertiary. Okay. So we're looking for a primary prevention program here. Correct answer is B. Right? Why is the correct answer B?
Because that can prevent pregnancy.
Okay.
It's preventing pregnancy.
Okay. Does everybody understand that? Okay. What is A?
That's
What's A?
screening, that's secondary.
Primary, second, yep, it's secondary, right? What's C?
That's tertiary.
Tertiary,
Okay, why is that tertiary?
because it's educating them on the side effect. That means they already have it.
That means they already have it, exactly.
Can I have some?
Okay, and then what about D? What's D?
That's tertiary too,
Why is that tertiary?
because she's already pregnant.
Okay, does everybody understand that? Does everybody understand why each of those are either primary, secondary, and tertiary? If you don't, speak up, because I want to explain it to you. Okay? All right. Which counseling is appropriate to provide the pregnant adolescent? The correct answer is A. Why is A the correct answer?
If they still can get STDs during pregnancy.
Exactly. Everybody hear what Vanessa said? Because just because they're pregnant doesn't mean they're free of risk from contracting STDs, right? Why is B wrong?
Because they should modify their diet.
Because
To
they
include-
are going to be on a modified diet, correct?
Yeah, to include vitamins and
Because they're pregnant.
Yeah.
Okay, why is C incorrect?
Because
Go ahead.
you should start prenatal care at the very beginning when you find out you're pregnant.
Absolutely. Absolutely. And then why is D incorrect?
Because you probably shouldn't assume that they want to give their child up for adoption.
Correct. That adoption decisions or discussions don't have to happen early. The earlier the earlier the better. That doesn't make any sense. Adoption discussions can happen throughout the pregnancy, right? It may be in the early stages of pregnancy, it may be way too early to have that discussion. Anybody have any questions about question 2? Or don't understand why it's right and why the others are wrong? Okay, question 3, which intervention should be prioritized for a child who has witnessed a violent crime? What's the key word in this question?
prioritize.
Prioritize.
Prioritize. This is a priority question. In some of my tutoring this morning, we determined that Students are missing questions that have key words or phrases or cues in them that might help guide them to the correct answer. This is a question in which an example of a question, and I mentioned this with the previous quizzes, where more than one answer looks like it could be correct. And so what do you need to do? If more than one answer looks correct and it's not a select all that apply,
Look for the most right one.
well, you need to go back and look at the question and see what you missed. Right? Here, A could be correct. B could be correct. C, D could be correct, but it's asking what should be prioritized. Okay, so the correct answer is C, obtain a referral for mental health counseling and services. So again, I gave this tip to a couple of students this morning, but I'll just mention it to the whole class. I don't know if you do or do not take advantage of the highlighting service that is in ExamSoft. But if you do not, you might want to consider using it. Lots of students find it very helpful when you go through and read the question, you can highlight a particular word or a phrase or a cue that may come up so that when you go back and read the question a second time, that word pops out. So the key word in this question is prioritized. Okay, all of the answers could be correct, but it's asking for the priority. The priority is to obtain a referral. Does anybody use the highlighting? I'm just going to take us off. Does anybody use the highlighting technique?
I do.
Yes, I use it.
Is it helpful?
I do too.
Yes, it
Yes.
is.
Yeah.
Yeah. Yeah. And if you haven't used it, maybe you try it for the next exam to see if that helps. Because a lot of times it's easy to skip over those priority words. Right? And like I said, this particular question is a great example of if more than one answer looks correct, go back and read the question, see what word you missed. Question 4. Which nursing intervention reflects secondary prevention for mental health? Well, what's the key giveaway in A?
Screening.
Screening. All right, secondary refers to screening. What is B? Primary, secondary, or tertiary?
Tertiary.
Anybody else have a thought?
Primary,
The primary
Why is it primary?
because you're preventing them
teacher.
from
Yeah.
being stressed. Like,
You're trying to get ahead of it, right? Teaching them some preventative stress reduction techniques that may help them. Okay. What is C?
Tertiary.
That's tertiary.
Why is that tertiary?
They're already depressed.
Does
So they
everybody
have-
understand that? They're already depressed. They already have a condition or a diagnosis going on. And then what is D?
I'm tertiary. Because they already have PTSD.
Right. Does everybody understand those? Okay, these are a lot of good questions with primary, secondary, and tertiary. So if you're not understanding it, you need to reach out or speak up or let me know. Which nursing assessment is the most important in clients abusing oxycodone? What's the key phrase in this question?
Most important.
Does everybody see that? For anybody that got that wrong, what were you thinking? If you didn't select C, did you catch on to most important?
No.
Okay, most important. The others are other symptoms that somebody may experience, but it's asking what is most important. So this is not only a priority question, but it's one of those ABC questions. What do I mean when I say ABC questions?
Airway, breathing,
Circulation.
circulation.
Safety, right? This is also characterized as a safety question. Okay. Anybody have any questions about question 5? Okay, number 6, which reflects tertiary prevention in substance abuse? Correct answer is tertiary. They have to have something. So arranging an addict-led support group to promote recovery. Does everybody understand why that's tertiary? Okay, what is A? What's A?
Secondary is screening.
Does everybody understand that? What's B? Anybody? What's B?
Prevention, primary.
What?
Primary,
Primary. Why is it primary?
because you provide the information.
Right? It doesn't say they have a substance abuse issue yet. You're trying to prevent something before it happens, correct? And then what is D?
It's
Primary, what is helping parents?
Is that tertiary?
Why would it be tertiary?
You're helping them with the cope
Because you gotta help, you helping them coping.
with whatever they have.
Yeah, they already, I guess, dealing with it.
What do they have? That it would be tertiary.
Helping parents, role model, that.
I'm
guess
just-
it's substance abuse.
This would be primary, right?
Oh,
Helping
primary.
parents role model coping mechanisms. It's not identifying that there's an issue yet,
Mm.
right? Question 7. What's non-malfeasance? What is that?
avoid causing harm to someone.
Do no harm. That's in your ethics concept, right? So what's happening in A that makes this non-malfeasance? Do no harm.
Yeah, because they contaminate the sterile field, so they're getting a new one. So they
You're
don't
trying to avoid any harm.
infection. Yeah.
Do you understand why B is incorrect? Inserting a feeding tube to administer meds with somebody who swallows fine. That's doing harm. Failing to document observed side effects to administered medication. That's doing harm. And maintaining confidentiality of a fellow nurse who is working under the influence. That's doing harm. Do we all understand that? What's the other ethical principle that goes along with non-malfeasance? We'll get to this in our content, but go ahead.
Beneficence
Beneficence,
to do the most good in any
Right.
situation.
doing good. So we have beneficence, that is do good, and we have non-malfeasance, that is do no harm. Those are the two most important ethical principles. Question 8, hospice nurse notes that a client's pain is poorly controlled despite the fentanyl patch and as needed sublingual morphine. Which intervention is appropriate? Why is B correct? What are some key words in that question?
Pain is
What kind
poorly
of an
controlled.
environment is it?
Hospice.
Hospice. Okay.
Pain is poorly controlled.
And, yep. And so what are we trying to achieve when we're caring for hospice patients?
Comfort, pain-free, like a peaceful death.
Mhm. So it would be perfectly okay and appropriate to notify the healthcare provider for additional pain management. Why is A incorrect?
There's no risk of addiction.
We don't really care about addiction at this point, right? We don't really care about addiction. This is about end of life care. Okay, why is C incorrect? Anybody? Abigail's doing all the answers. I want others to jump
Because
in.
that's kind of being insensitive to telling them that having a pain-free death should not be expected. To me, that's kind of a little insensitive to tell somebody.
Well, it's not only insensitive, but that's really not the expectation.
Yeah.
Expectation is that as pain-free as it can be, that's what will be provided, right? And then why is D incorrect? What's wrong with that answer?
Because you're supposed to be trying to prevent a pain-free death while they're in hospice.
You're what?
I guess because you're trying to prevent pain-free death while they are in hospice. Like
Okay,
you're trying
but
to manage their
what
pain.
what's wrong with that answer?
You never
What's
put
Because
wrong?
it's
it
saying
on in the same location.
Exactly. Right? You wouldn't put a new fentanyl patch on the same location, right?
Right.
Question 9, the client tells the hospice, again, we're in a hospice patient, I do not understand why God is punishing me. Which response is appropriate? We always have a discussion about this. The correct answer is, do you have a pastor I can call for you? Okay. In hospice care, there are certain things that we can address with the patients, and there are certain things that may be beyond our scope. And the reason why number 2B is correct is because what they have said. Are you prepared as a hospice nurse to discuss the answer of why God is punishing me? Or might it best be left to a pastor or a religious person? Why would A be inappropriate to say?
because it's not therapeutic. Asking God for your forgiveness after they're going through a dying stage and they think they're being punished. It's not a therapeutic response to say, let me pray with you for forgiveness.
Right. You're almost acknowledging what they're saying. They're being punished, and you're saying, okay, well, let's talk about forgiveness. Right? So you're correct, Kadisha. Why is C incorrect?
Because you're also telling them that it's a normal part of life and you're not acknowledging their distress that they're in.
Right. That's a pretty insensitive thing to say.
Mm-hmm.
Right? And then a lot of students pick D. So why is D incorrect? The response I get from students is we're trying to acknowledge, they think it's the correct answer because we're acknowledging what they're saying. However, with a hospice client, why would this be an inappropriate? For a specific hospice client, end of life care, why would D be inappropriate?
Because there's different phases that you go through in the process of dying. And this might be like what do I want to say? Denial phase or whatever. Like, and
In
they're
this-
like, they think, and they're, you know, how stages of grief,
Mhm.
and they're not at the acceptance stage yet. So they think they're being punished. What makes you think you are being punished or whatever? And it
Mhm.
just leads to a bigger problem, I feel like they're dying, you know what I'm saying? I don't know.
Yeah, no, that's,
but
go ahead.
But it's like in the, what you say in the stages is in this question involve like many meanings. Like can be in the last stage, in the beginning, or Bulgarian, because it probably is like a Bulgarian.
Mhm.
I don't know if he's in the last stage or is dying. Maybe
Well,
he's
the-
complaining only because he's sick.
Right, that's part of it. What I wanted to add was if you ask them what makes you think you're being punished, then you're asking them to articulate what they may have done that was wrong, and that may stress them or that may be painful for them to explain. You don't want them to try and acknowledge why they're being punished, because that just brings up things that we don't want them talking about right now. Right?
Mhm.
Does that make sense?
Yeah.
Pardon me. All right, last question. Excuse me. A client with metastatic cancer has made the decision to stop all therapies. Which statement by the nurse reflects the nurse, which statement by the nurse reflects the respect for the client's autonomy? What is autonomy? What did you learn about autonomy when you were reading about end-of-life care?
Independence, and the ability to make your own decisions.
Mhm. Yep. So that's why A would be the correct answer. Okay, they have made their decision. They're being autonomous. And so the next question would be, would you like me to help share this information? Okay, why is B incorrect?
Because you're not acknowledging that they want to stop therapy, and radiation is like medicine, or like, yeah, it's not.
Well, the patient has already said, I want to stop all treatments. So why would you want to bring in a physician to talk about radiation? What's wrong with C? What's wrong
As
with
a LPN, how LPN we are allowed to sharing the decision with the family, or we need to tell our in charge nurse for them to talking with the family.
Well, it's okay for us to ask if they may need help sharing the decision, right? They can say no. They can say no, but that means we have acknowledged and accepted what they've said. They may need help or they may not.
Yeah, well, I understand that point, but my question is, the LPN is allowed to sharing with the family the decision of the patient or not?
Yeah, you can if you have the patient's permission to, sure.
Okay.
Sure. What is wrong with C?
It's their choice,
It's
not the
not,
family's choice.
Go ahead, Kadisha. And somebody else tell me about C. Why is C wrong?
I was just gonna say that they wasn't respecting their autonomy.
You're gonna say what? Say that again?
They wasn't respecting their decision because they wanna make sure their family is okay
Correct.
with it, but it was, yeah.
Right. Why would you question their decision? If they're competent to make their own decision, why would you question that? That shows a complete lack of respect for their decision making. And what about D? Why is D wrong?
she's trying to convince her that the chemotherapies aren't bad and that she should continue to get them.
Right. You're disrespecting their decision again. So having gone through that and knowing the questions you got wrong, do you have a better understanding? Okay, let's go through the content. We got a lot to cover, and please jump in if you have any questions. Okay, we're going to go through the notes from week 4 from last week. All right, have you guys been taking the opportunity to review these notes? They're pretty detailed on what's being
Yes.
covered.
Mhm.
Okay, so some of the special vulnerable populations were the pregnant adolescents, which we had a question about, LGBTQ, mental illness, and alcohol and tobacco. Okay, and other drug problems. And if you've if you did your reading, we had readings from each book last week. Okay, and you had the PowerPoints that go along with the full chapters. Okay, and hopefully you recognize when it said See Canvas course, there were 3 different teaching pages. There was one on pregnant adolescents, one on LGBTQ, and one on mental illness. Did everybody see those and review those?
Yes.
Okay, does everybody know what I'm talking about when I say Canvas reading? At this point, you should, because each week we have had Canvas reading. We didn't have it last week, or in week 3, but we did have had it. Okay. I need everybody on camera, please. I'm looking at walls, I'm looking at ceilings. If everybody could be on camera, I would really appreciate that. So let's first talk about our special vulnerable populations. All right. What do we know about special vulnerable populations? We know that they potentially are going to have a higher risk for poor health outcomes with regards to morbidity and mortality. Okay, special vulnerable populations also have a higher incidence of chronic illness, STDs, maybe TB. Special vulnerable populations also have a higher risk of poor living conditions, poor diet, poor health status, exposed to more crime and violence. Okay, let's talk about the pregnant adolescent. Okay, we know there's a direct correlation between poverty and poor health outcomes with this group. Why is that? What's going on with pregnant adolescents that make them a special vulnerable group? And I'm asking everybody, what's going on?
They don't have education. Their education, they need more education on the on like their environment.
Okay, what else?
They're young and they're in school, so they could potentially not finish school.
What else? I need others to jump in here, other than Abigail and Kadisha. What else is going on with this group?
Drugs and alcohol.
Drugs and alcohol. What about prenatal care?
Most of them don't get it early on. It's usually later when they find out.
Okay. Why else are they at risk?
STDs.
Yeah.
Okay. One of the
Abuse,
biggest
violence. I was just going to say abuse and violence. I remember reading this because I was a pregnant adolescent And some of the points that they put up to me was kind of interesting or whatever, just about the sexually transmitted disease, the higher risk of poverty, you know, abuse,
Mhm,
and things like that. So it's really interesting to me.
mhm. Does it correlate with your experience?
Not really. I mean, I did have obstacles. I had a lot of obstacles to jump through. I did have a lot of struggles from being pregnant at 16, but it was never because I was abused
Mhm,
or
mhm.
I was addicted to any drugs or
Right.
anything like that, you know. So it was just like dropping out of school, you know, some of the babies died,
Right.
birth outcomes and things like that. So I didn't have those kind of outcomes to me. So I mean, it is a valid point, and I know a lot of people do, but it just wasn't
Well,
for me. I guess it made me want to go harder, especially going to school. I wanted to go to
right,
school. I wanted to finish school. I wanted
right.
to get housing. You know, I wanted to be better educated for my children too.
Well, all the risk factors don't apply to everybody. I mean, there may be one risk factor that applies, or there may be 10 risk factors that apply. We're just going through the generic risk factors of a pregnant teen. Like you say, you may have experienced some of them, but didn't experience most of them. And so let's talk about that for a minute. What are resources and what are some resources that pregnant teens may have that prevent them from having all these risk factors? What would be helpful?
A good support system. Like,
Support systems. Absolutely,
Mhm.
support systems. Supportive families,
Education, absolutely,
education,
absolutely.
education. They stay in school. Exactly. What else?
The social economic education as well, just what's going on in the community, what can help them or
Right.
and
Are
things
they
like
living
that.
in poverty or are they not
Right.
living in poverty? That makes a big difference.
Hmm.
Right. So we know that there's a direct correlation between poverty and poor health outcomes with the teen, pregnant, adolescent. All right. The biggest issue we talked about was dropping out of school. Okay. When there are programs that are offered to these teens to stay in school, that's going to give them a much better shot, a much better shot at making better decisions for both them and their baby. Okay, it will improve hopefully improve their view of healthcare over the lifespan. Right, so it's critical to keep these kids in school. And if they do drop out, it's critical to try and get them re-enrolled back in school as soon as after birth. Okay, pregnant, and you take it one step further. Not only are you a pregnant teen, but what if you're a pregnant homeless teen? That presents even more challenges. This particular group, higher rates of STDs, higher rates of abuse of alcohol and drugs, poor nutritional status, maybe a higher incidence of poor birth outcomes. So with regards to a pregnant adolescent, one of the biggest risk factors is going to be if they're homeless or not. Okay, homeless is the most dangerous sign. All right. What do we want to look for in these pregnant adolescents? Do they have blood pressure issues? Do they have STDs? Are they seeking prenatal care at an appropriate time? Typically, racial and ethnic minority groups have the highest risk of teen pregnancy. Why is that? Because they also have the highest rates of poverty, lack of educational opportunities, higher rates of abuse, violence, sexual victimization during their pregnancy. Some factors that contribute to your teen pregnancy: low income, lack of education, lack of social support networks, And maybe the living environment, abuse, trauma, neglect, sexual victimization. So we know that teen pregnant people are at much higher risk of abuse. So if we're visiting, let's say we're a community health nurse, and one of our roles is to visit new teen moms with new babies. What are some of the things we want to look for? What are going to be some some identifiers of red flags? What are we looking for?
Poor living conditions.
Yep. What else?
Maybe like the baby's not clean.
Mhm.
Mother and baby bonding.
Yep. Excellent. Knowledge about growth
How
and
they're
development.
coping.
Say that again. What'd you say?
I was just saying how they're coping after having a baby, because you know some people go through depression and things like that. So.
Absolutely. Yep. How to identify signs of postpartum depression. Right. The
Possible
goal.
substance abuse.
Yep. Yep. Knowledge of growth and development. Are they meeting the baby's needs? When the baby's crying, do they know what to do? Okay. So really important in that new postpartum assessment of the teen, of being able to identify what's working and what's not working. Okay. Here's some examples of primary, secondary, and tertiary with regards to the teen pregnant mom. So primary, we're trying to prevent a pregnancy. So maybe we're educating on developmentally appropriate sex education. Sooner the conversation's happen, there's a lower risk of an unintended pregnancy. And for purposes of this discussion, many public schools they don't have sex education programs anymore. They used to. And so that becomes the burden of the parents to have that discussion. So one of the things we can do is work on educating the parents on how they provide sex education in the home.
Or just
Okay.
making them feel more comfortable with having that discussion, because a lot of parents don't feel comfortable with that
Absolutely.
conversation.
When I was working in the schools, we would have, for our high school parents, we would have seminars or meetings, or informational nights on how to have that discussion with your high school student, right? Not only would we try and get to the kids during the school setting with educational programs, but we would also offer it to the parents. Okay, secondary. Who are our high-risk kids for an unintended pregnancy? How do we screen? Identify high-risk adolescents. Maybe kids with a history of substance abuse, history of sexual, physical violence, or emotional abuse. Kids that live in poverty. Vulnerabilities. So what do we do when we identify the at-risk students? Provide resources, provide STD screening, provide pregnancy testing. And then tertiary, they're already pregnant. So then we're having to identify what immediate needs are for the teen pregnant mom. Right? Does she want abortion information? Does she want adoption information? Does she want to go back to school? Is she planning on going back to school? What kind of support services does she have? We have to identify what her most pressing needs are. We have to be able to assess nutritionally. Is she on the right vitamins? School we talked about, getting back to school. And then we talked about teen mothers may struggle with bonding. Okay? So lots of things to consider if you're working with a teen pregnant mom. Okay, as far as LGBTQ population, why is this population considered a special vulnerable population? What goes on?
They have so many problems to be accepted.
Say that again?
They have many psychological problems, and to be accepted. Many changes in their life, and they need to be, or the population, and then they need to be adapted, and the changes, that changes is what they create a problem, many problems.
Good. What else? What else did you learn in your reading about the LGBT population?
They had disorders and how nutritional disorders, they have depression, they have suicidal thoughts. They change a lot of things.
So there are risk factors. Definitely an increase in risk factors, correct? One of the things that we need to understand as nurses, we are obligated to provide culturally competent care. And this is the first introduction into cultural competence. It comes up through the whole term. Okay, but this is a good example. This is a good topic to bring up cultural competence. What is cultural competence? What do I mean when I say that?
An understanding of our own culture and approach people as unique and look at the world through their eyes.
All right, so this is our first test with this particular population. We're obligated to provide culturally competent care, right? So with this particular population, there's some nurses that may feel a sense of discomfort, right, when discussing sexual orientation with this particular population. But it's very important for us to overcome whatever barriers we have to be able to communicate and care for the LGBT population. We have to understand our own feelings, right? We have to understand our own biases if we have any. Okay. One of the most important things to do is we have to provide a safe environment for this population to be able to discuss their sexual orientation. We're not going to be able to do that if we haven't come to grips or come to terms with our own feelings. Right? With this particular population and really all vulnerable populations, we have to be able to take an open, non-judgmental sexual and social history with this particular population, which will help build trust. Remember, we talked about in our introduction to vulnerabilities, one of the most important things with any vulnerable population is building trust. Right? We can't make assumptions. We can't be judgmental. We can't make assumptions based on appearance or sexual behavior. Open-ended questions. Okay, for example, and there's some examples here in your note, rather than asking a client, maybe from the LGBTQ population, are you married? Maybe we say, do you have a partner? Right? Or do you have a boyfriend or girlfriend? How about, do you have a partner? Okay. So it's trying to ask questions that don't make the assumption of heterosexuality, right? If you say, do you have a boyfriend or girlfriend, that assumes heterosexuality, right?
What is that? What is
when you're not LGBTQ, it's a man and a woman. So you don't want to ask questions that assume that. If you know you're working with somebody in the LGBTQ population, you have to be able to find a way to ask the open-ended questions, such as, do you have a partner? You're not saying, do you have a boyfriend or do you have a girlfriend? Do you have a partner? Okay. The Centers for Disease Control and you'll be asked this on the next exam. They have recommendations, screening recommendations for the prevention of STDs. And I'm in this paragraph here. Please understand what these are. Okay. Yearly screening for HIV, genital herpes, syphilis, gonorrhea, and chlamydia. Okay, there's an annual recommended screening for all of those. Okay, so HIV, genital herpes, syphilis, gonorrhea, and chlamydia. Okay, the recommended interval is annual. However, if the client is particularly at high risk for STDs, such as having multiple or anonymous sexual partners, or those that are using illicit drugs, okay, the recommendation then is every 3 to 6 months, not annually. Important to remember. Okay, so have an understanding of what the annual requirements are, recommendations are for annual screening, and have an understanding of the shortened time frame if they're more at risk. Okay, so the key with the LGBT community, what I want you to take away from is being culturally sensitive, expressing or looking at your own feelings, being able to give them a comfortable environment for them to be able to share their social history, their sexual history, and being able to ask open-ended questions as to not make them uncomfortable. Okay. Mental illness, big problem, big problem. We have seen the increase in mental health cases explode over the last 3 years, right? All ages. I saw it in the schools during the pandemic, starting in preschool all the way up to high school. Have you guys in your community seen in your clinicals, in your other classes, in your community, have you seen an increase in mental health issues?
We actually just went to a mental health clinical, and I have to say it was really different than what I expected to see.
In what way?
Especially just how you think you could point out a mentally ill person, like, you know, oh, he's acting out, or he, like, I don't know how to say it in a I don't know how to say it or whatever. Just they were like normal, like, and they were children as well, and you wouldn't even know these people had mental illness, and that's like in the community today too, like. And it was crazy to me to see the children. They look like normal children or whatever, but they just had these things that they go through, like emotionally or whatever. But they saw us at clinical Saturday, and they were all nervous because they thought we were like doctors because we had on the white coats. So they were acting different just for the fact that they were scared that they were going to get an injection, you know?
Mm-hmm.
Like, it was just different to me to see it, like, to see it where they live at, where they, like, the hospitals look like jails to me, like the way they are and stuff like that. Like, it's crazy. And just to hear, like, read the reports and then them tell us why they're here and the stories not be the same or whatever, I don't know, it was just really different to me. It was an eye-opener because it really is something that people don't look at, like, but it's really going on. Like, somebody in our class right now can have be mentally ill, but they just know how to, like, deal with it, rather than the people that's in the facilities and things like that, or they don't have anybody, because most of them are like in foster care, or they don't have their family. Like, it's sad. They don't have the support that they need to be able to live in society with their illness. It was really sad to see.
What kind of facility were you in? Were you in a mental hospital?
Yes, it was called Laura Woods or something like
But
that.
it was a mental health
Windsor.
facility.
Yes, it was.
And
It
was
was like a hospital, actually. It was a hospital.
so clients that have been committed to the hospital, and I assume it was of all age groups.
All age groups from 5 and up. Literally.
Yeah.
A 5-year-old was there. I'm like, wow.
Right.
Yeah, it was definitely different to see.
Well, thanks for sharing that. Anybody else has anybody else had any mental health clinicals to share?
No, I think more in mental health. Well, I'm not in mental health yet.
Mhm.
I work in the senior behavioral unit at the hospital.
And
It's quite scary most of the time. Even though they're elderly, it's still don't ever know.
yeah.
Mm.
Yeah. Yeah, very scary, the trend going on right now with, like Kadisha said, all the way from kids all the way up to the elderly. Really scary. So when we talk about mental illness, there's a couple of conditions that I want you to be aware of. All right, first of all, let's talk about anxiety. Anxiety is expected. It's a common emotion. Okay. However, anxiety can become so debilitating that it just really prevents somebody from daily functioning to their fullest extent every day. When you have abnormal or debilitating anxiety, sometimes it feels life-threatening for the individual. Interestingly enough, 30% is hereditary with regards to generalized anxiety disorder. Okay, why are these kinds of clients at risk? Maybe physical issues, psychosocial issues, developmental issues, cultural, spiritual, maybe affecting their lives. And a lot of times, patients with the anxiety disorders have other mental health issues, such as maybe a depression, substance abuse, bipolar. Okay, so this section on mental illness I've highlighted the 5, I think it's 5, and I have a paragraph about each one, right? We need to be familiar with what is generalized anxiety disorder. Okay, somebody with generalized anxiety disorder presents as having a persistent, unrealistic, or excessive worry about 2 or more life circumstances for 6 months. That's the definition. Okay, it typically develops slowly and becomes chronic. Right? They're often worrying about, think about a generalized anxiety disorder. They're typically worrying about lots of things at the same time. Okay, instead of being particularly focused on one issue. Right? Here's an example. A person may be worried, somebody may be worried about taking an upcoming test. And then once the test is over and the grade is posted, anxiety diminishes or disappears. That would be normal. But in somebody with generalized anxiety disorder, they may not only be worrying about the test, but also whether the test will result in a failing grade, which could culminate in being dismissed from school. They take it several steps further, where they don't even have the information yet. Does that make sense?
Mhm.
Somebody with a phobia, right? What's a phobia? Irrational fear of a specific activity, situation, or object. I have a phobia of snakes. Okay. Even seeing pictures of snakes gives me extreme anxiety. Okay. Lots of people have different phobias. Okay. Maybe people are fear of heights, fear of spiders, fear of elevators, claustrophobia. And it's interesting that phobias tend to run in families. And then you have your client with OCD. What's OCD? Recurrent, intrusive thoughts that you cannot stop thinking about. And those thoughts create anxiety. All right. Let's do an example. Performing repetitive hand washing.
OCD.
What are some other OCD behaviors?
Categorizing things like hanging clothes a certain color in the closet together, kind of.
Wash the hands.
Pardon me?
Wash the hands.
Washing
very
their hands.
often.
Yep.
Have it be also sit with the clean stuff. Maintain everything clean in house.
Recurrent thoughts. Recurrent. They can't stop thinking about it. Always thinking about washing their hands.
Like
Oh, and with the COVID, the always the wearing of the mask. Right? What else?
Everything's gotta be the same. Like the same routine, same stuff that they do.
Yeah.
If it changes,
We watched
then
a video
obviously-
on that.
Oh, you did?
But-
Okay.
but
What'd you
they are-
learn?
They become obsessive even with the other people to push the others do the same, like maintain clean, wash your hands, or use your mask, or why you do that. They become very obsessive.
Yep. And then we have post-traumatic stress disorder. There's some kind of a previous event that either threatened death or threatened serious injury to self or others, in which it created an intense fear, intense anxiety, experienced helplessness, hopelessness, right? And the remembrance of that event produces feelings, ongoing feelings of intense distress, intense anxiety, may actually have nightmares or flashbacks. Okay, we see this a lot with our veterans. Okay, so PTSD is one of the mental disorders for us to know about. We know that children are at high risk in all vulnerability. Kids are at high risk for mental disorders, right? Maybe secondary to some of the adverse circumstances in their life. Circumstances that create a disruption. Okay, maybe they live in poverty. Maybe they're witnessing violence, domestic violence. Maybe they're being victimized themselves. One of the medications that I want you to know about is lithium. Hopefully you already know about lithium. Okay, lithium is used for bipolar.
They need to check the serum lithium because they can have toxicity.
Say that again?
They need to check the serum lithium values because they
Oh,
can
absolutely.
have toxicity.
Checking the serum lithium. And you also want to make sure one of your teaching points is encouraging normal salt intake and report any diarrhea, vomiting, tremors, or lack of coordination. Those are some side effects of lithium that you want to teach your client that's on that to report. Okay? So those are the mental health disorders that I want you to be aware of. Okay? They're all lined up for you and gives you information on each one. And then please have a look at lithium. Another vulnerable, special vulnerable population is our population that has issues with alcohol, tobacco, or other drugs. We know that substance abuse contributes to lots of things, right? Contributes to teen pregnancy, contributes to HIV, contributes to STDs, domestic violence, child abuse, car accidents, fights, violence, crime, homicide, suicide. Substance abuse is a huge issue in our country. What are some contributing factors to substance abuse? Whoops.
Homeless?
Some,
The minors, they try to feed in the social status or coping mechanisms,
Peer pressure?
yeah, like coping mechanisms for the teenagers.
Yeah.
Or to be
Trying to
accepted in
escape.
the groups.
Peer pressure is big on how it gets started, though.
Absolutely. So some people are genetically predisposed, right? Others are afflicted by this from maybe a mental health disorder that they have. People with underlying mood disorders or mental disorders may try and self-medicate with the psychoactive drugs, right? And sometimes the exacerbation of these additional medications just makes things worse, right? Drug addiction, substance abuse, social factors, physical factors, cultural factors, all these affect substance abuse. Okay. Here's some definitions to be aware of. What's the difference between substance abuse and drug dependence? What's drug addiction? I'm going to have you guys read through these because I want to move on to our week 5 content. But I want you to read through these. What's alcoholism? What's polysubstance abuse? And certain kinds of drugs, psychoactive drugs. We have depressants, we have stimulants, we have energy drinks, we have nicotine, vaping, alcohol, cocaine, amphetamines, methamphetamines. So just have an idea of what the different categories of drugs are. Okay, we have plenty to choose from. And then have a look at the primary, secondary, and tertiary interventions for people with alcohol, tobacco, and other drug issues. Okay, so I'm going to have you read through that. And there's a good section at the end here where what would we do if we were a community nurse and we were setting up activities aimed at substance abuse prevention? What are some of the things as nurses we could do? And here's a list of these. Okay. Let's jump to our concepts for this week. Does anybody have any questions about the special vulnerable populations? I mean, we are going to be taking care of or being exposed to lots of special vulnerable populations in our nursing career. It's important to be able to recognize them and come up with a healthy plan of care on how to work with them.
I feel like I understand it. And I'm sorry, I don't want to take up too much time, but I feel like I understand the concepts of things like that. But when they throw it into like an exam, the questions be like kind of different, you know?
Well, in what way?
Sounds
'Cause I
like
know the
everything is related, but no everything is related in the exams. It's confused. Like all the questions in some point have a little related with the questions.
Or it could be like 2 of them, like, because you know the priority is education, you know, so anything with education, I'm like, yeah, that's it, because we got to educate them on how to do this or give them a pamphlet on, you know, so I don't know, maybe
So
it's just me.
part of the exams are made up of concepts, right? So the hope is that you have an understanding of the concept of, say, vulnerable populations. So you may get questions about teen pregnancy, mental illness, alcohol and drug. But the goal is to have an understanding of the concept in general. Okay? So yes, and the other part of that, let me finish, is that the questions on the exams are clinically focused. So if, let's say you're presented with a teen pregnant mom. Okay, they're clinically focused. What would you, what's the most important thing to do with a teen pregnant mom? Let's say one of your answers, the most important thing, keep her in school. Okay, so yes, there's a lot of concepts to cover, but the questions are asking you to take the knowledge that you've learned from these concepts and put it into practice. Does that help? And really what this class is an overview. It's an overview of these particular, there's a lot of concepts we go over. And we're creating an overview of the concept. And so the questions you get are based on the overview knowledge that you've obtained. Does that make sense? I'm trying to explain it in a Kadisha, does that help?
It does. It does. I would just, I don't know. Maybe I just read them too fast. But that does make sense. I am understanding the concepts or whatever, just putting it into play, I guess.
Right. We talked about this early in the term that these exams are clinical. All right. It's taking what you know and putting it into clinical practice. And so that's what you need to be focused on. When you get your study guide and you look at the concepts, what questions might I be asked about teen pregnancy? What questions might I be asked about mental illness? If a patient presented with generalized anxiety disorder, how would I know that? What are they exhibiting? Right? If a patient presented and they said they were on lithium, or if I was taking care of a patient and they were going home on lithium and I was responsible for teaching, what would I teach them? Right? That's where the questions are coming from. You're not expected to memorize every bit of all the notes, but what you are expected is to have a general knowledge of the concept. Right? And like I said, the exams are completely clinically focused. That's the whole next gen model. Taking your knowledge and applying it to critical judgment. Okay? All right, this week, hospice palliative care, death and dying, faith and spirituality, those all kind of combine into one topic, and then we have ethics. Okay, so let's review hospice. What's the difference between hospice and palliative care? Where's the difference?
For people who have terminal disease, and they give the other treatments that are no like medications, other kind of therapies or type of food, different type of food. And the long care, this when they go with treatment and just care, the treatment of them to rehabilitate it, or not rehabilitated, but take care of the disease of their
Right? Anybody else want to add to that? What's palliative care?
Palliative is stopping like treatment like chemo or radiation, focusing on the quality of life in a terminal illness. And hospice is for a patient who's dying and they want to present quality care for dying. They have 6 months like left to live.
So palliative care can go on, right? Palliative care can go on until hospice becomes a necessity. Does that make sense? That's a difference between palliative and hospice. Let's say you're diagnosed with cancer today. Okay, and you're given, I don't know, 12 months, 2 years. Palliative care is through that process. But when it gets close to the end of life, that's when it turns into hospice. Right? So palliative care can be chemo, it can be radiation, going through all of that. Hospice is when the actual end of life signs and symptoms start. All right. One of the focuses, a couple of focuses on the hospice and palliative care, death and dying, keeping the client comfortable, maintaining dignity and self-esteem. Right? Although we want to control the pain, we don't want to keep the client so sedated that they're completely unaware of what's happening. Right? We still want the patient, this is hospice now. We still want the patient to be able to interact with the family. We still want them to try and be autonomous in their decision making. You had a couple of quiz questions about that. We know that family is very involved in hospice care, but you've got to remember that the client's needs are most important. Okay, so if the client says, I'm done, I don't want any more treatments, I'm done. The family can't, and the client is autonomous and competent and can make those decisions. If the family doesn't agree with that, that can't supersede what the client wants, right? We do everything we can do to maintain the dignity and the self-esteem of that client, right? We're trying to alleviate suffering as much as possible, right? One of the things that sometimes is a misconception is patients are still looking for a cure. Okay, when we're in palliative and, well, especially with hospice care, there is no cure, right? Our goal is to try and maintain the best quality of life that we can for these clients, right? Trying to have them accept death as a normal and expected part of life, right? So we're focusing on the quality of life rather than the quantity. And symptom management. Maybe they need spiritual support, maybe they don't. Maybe they need psychosocial support, maybe they don't. It's up to that hospice nurse to assess all of that. And the one thing to remember with a terminally ill patient is the dehydration. Okay, a lot of people don't realize this, but dehydration in a terminally ill patient has actually been researched to decrease the pain and is actually more comfortable to the patient than when a feeding tube is inserted or they're getting IV fluids to reverse that dehydration. Sometimes dehydration can be shown to actually have the patient be more comfortable. So remember that. Hospice and palliative care are provided in numerous kinds of environments. Home, long-term care facilities, clinics, bigger facilities. We know that hospice is the end stage. We already talked about that. Right? Palliative care is to improve the quality of life. Okay? So according to the World Health Organization, the goal of palliative care is to improve the quality of life for patients and their families while they're dealing with a life-threatening illness. So do you guys understand the difference between palliative and hospice? Some types of support we provide. Physical support. Maybe we're trying to alleviate pain, reduce air hunger, improve sleep. Social support. Facilitate relationships that may be strained or may have been neglected, that the patient communicates they might want to mend. All right, maybe updating the will, saying goodbye. Spiritual support if they desire, finding peace with God or whatever the higher power is through the chaplain or spiritual advisor. That was one of your quiz questions. And identifying the stages of grief so you can follow along with where the client or family members are in their stages of grief. You may have family members all over the board that may be in different stages. Okay. And then this paragraph talks about the stages of grief. What may the client or family members be exhibiting behaviorally that will help you identify what stage of grief they're in? Okay, so that's that. We don't want to be making decisions for the client and the family if they're capable of making their own decisions, right? We want to provide them as much autonomy, as much decision making, as much control, if you will, in this process. Therapeutic communication. Asking open-ended questions, avoid making assumptions, don't offer platitudes, pleasantries, right? Such as like, everybody dies, you're not being punished, or I'm sure God will forgive you. And the hospice nurses, has anybody ever worked with a hospice nurse for a family member? Hospice nurses are, they're
amazing.
yeah, they're
My
angels.
grandma's a hospice nurse. She's been a hospice nurse for 25 years
Yeah,
in
yeah,
the same place.
yep. So with regards to hospice nursing, as death becomes imminent, clients spend more time sleeping, their appetite fades, oral intake decreases, urine output decreases, maybe some incontinence. Pulse usually goes up, blood pressure goes down. Skin and extremities become mottled and cool. Respirations become shallow and irregular. And you may witness some Cheyne-Stokes respirations. Okay? Providing hospice nursing care is mentally draining. Okay, and so nurses have to think about caring for themselves as well. It's really important to understand your own beliefs and attitudes regarding death. And prior to beginning any kind of this work, it's grueling work. It's grueling work. Okay, with regards to faith and spirituality, again, culturally competent care comes in. Okay, we need to have our own we need to understand our own feelings with regards to faith, spirituality, and culture. Okay, like Abigail said earlier, we need to approach individuals as they're unique. We make no assumptions. We do not place our culture above others, and that to the extent that we can, we have to try and incorporate different cultures, traditions, beliefs, values, practices into the health plan. Okay. Some cultures are past oriented, they're present oriented, or they're future oriented. You're going to get asked about this on the exam. Okay, what does it mean when your culture is past oriented? Right? Maybe you're so preoccupied, and this paragraph right here explains it all. Okay, you're preoccupied with past events that you're not focused on future. And a good example of this is Native Americans. Native Americans, if you're working with Native Americans, they're typically very past oriented. So if, let's say you're working in a clinic and let's say a family member's had a stroke or they've had triple bypass and they need to schedule all these appointments for the future. They're not future oriented. They're going to need help doing that. And that's no diss on them. It's that they're past focused and not on the future. So they're going to need help with future planning in that particular case. Present, let's say present oriented cultures, they're focused on the here and the now. Right? So they're focused on making decisions that are going to affect them right now, make them happy right now. All right. This kind of decision making also fails to plan for the future and doesn't help them consider planning for future consequences. And then future, let's say you're only focused on the future. You're more likely to make sacrifices now to achieve your future long-term goals. So what I want you to understand is there's 3 ways to look at things, 3 ways, and every culture may look at that time presence differently. Past oriented, present oriented, and future oriented. Okay? When do we attain cultural competence? This is important. That's why I have it in yellow, right? We attain, well, let me back up. Over 40 years in nursing, I've been working on cultural competence for 40 years. Okay? Cultural competence is a work in progress. Okay? It's finally achieved, finally attained when I or you can learn about people's cultures, diverse cultures, and try and look at the world through their perspective. Okay, how much, let's say I'm looking at the Hispanic culture, how much of their values, beliefs, behaviors, practices should I be incorporating into their health plan? Same with Native Americans, same with Vietnamese, same with Muslims, same with all different cultures. We are expected to be able to know what their cultures are about, what they value, what they believe, what they practice. If you don't know, what do?
Ask them.
Ask them. Okay? Faith community nurse. Some of you may never heard of a faith community nurse. Faith community nurses are nurses that work in a mosque, a temple, a church community, a temple community, a mosque community. Okay, where they're internally working with their congregation. Sometimes they're called parish nurses, right? It's a specialized community nurse that's much more community oriented than community based, meaning they're looking at the congregation as a whole. The difference is they also incorporate spirituality into their care. That's what makes them a faith-based nurse. Okay? They do, depending on what the congregation or the organization wants them to do, it can be lots of different things. They may be focused on health education, health promotion, community health seminars, grief support groups, working with teen pregnancy. It depends on what the congregation, what their goals are. But it's specifically working within the congregation. That's what a faith-based community nurse is. Does that make sense? And then last topic is ethics. Okay, one of the first things we need to do, focus on when we are making ethical decisions, is to, and think of your nursing process here. We need to identify the ethical issue that we're talking about. We have to have an issue. Before we can go into decision making, we have to have an ethical issue, right? And then we go through our nursing process. And I'm up here in the first paragraph. We obtain the facts. We look at approaches. We make decisions. We implement whatever we've set out to do. And then we evaluate the outcome. Ethical decision making is very, very complex, right? We need to understand the theories, the principles. What does it look like if we violate ethical principles? And what are the steps in ethical decision making? Think about it, right? Sometimes if you're working in a hospital, most hospitals have ethical committees. All right, what are they responsible for? They're responsible for looking at ethical dilemmas, whether it's an end of life issue, whether there's lots of ethical, whether it's whether we continue care or not. Okay, ethics is dealt with on an ongoing basis within all healthcare institutions. Whether it's your clinic, your neighborhood clinic, your emergency room, your hospitals, your long-term care facilities, your assisted living facilities, hospice care. And here's where we talked about non-malfeasance and beneficence. Okay, so here's the principles I want you to know about. Beneficence requires you to do no good. Autonomy is another ethical principle. Autonomy is, we already went through this when we talked about hospice, involving the patient in making decisions. Okay, advocacy, another principle. We want to advocate for our clients. Okay, so we need to know about beneficence, non-malfeasance, autonomy, and the other one is justice. Let me find distributive justice. Okay, so right here. So we know that beneficence is do good. Distributive justice. What's that? That means making sure that everybody has access to what everybody else has. That's distributive justice. Okay? So beneficence, distributive justice, autonomy, and non-malfeasance. Okay? So there's lots more in these notes. I want you to read through these notes, but we have ethical decisions to make every day, do we not? At our work, home, family, community, right? Ethics, doing what's right, doing what's morally right. So, I know I skipped through the notes on both weeks, but please read in detail about each of those concepts. All right, I tried to cover the most important things. Okay, but please, you're responsible for all of the notes. Does anybody have any questions?
No, I don't.
Okay, is this helpful information?
Yes, it is.
We
Thank
covered a
you.
lot today. We covered a lot today. Remember, these are overviews of specific concepts. These are concepts that you are going to find when you're working out in the community. Right, and it's taking all the it's shifting your mindset to taking the care you're providing, say in the hospital. Now that care is going into the community. Okay, like my students said a month ago, med-surg class in the community.
Mhm.
Right?
Yeah.
Okay. All right. That's it for me today. If you need to stay on and ask any questions or get with me, please do. If not, I hope you guys have a good rest of the week and reach out to me if you need anything, okay?
Thank you
And
so
then
much.
I'm working on the study guide for exam 2. Hopefully you'll have that in the next midweek. That's my goal.
Okay, thank
Working on
you.
it as we speak.
Thank you.
Thank you,
Alright.
Professor.
All right.